Dear Jean-Michel, dear Konstantin, dear ladies and gentlemen, dear colleagues, it's really a pleasure to be here. I thank you, Konstantin and Vasily, very much for the invitation the second time to the White Nights of Hepatology. As you heard, the topic of my talk is now the treatment experience situation. And at least in Germany, we have the situation that most patients that have been treated with triple therapy were treatment experienced. And treatment experienced patients can be clearly characterized according to their individual response pattern on dual therapy. And as you can see here, the response to dual therapy without a PI, without a protease inhibitor, is highly variable. And this is a type of a characteristic of this interferon-based therapy that you cannot really predict how a patient is going to respond. And you can see that in most patients you have at least some decline in viral load, some more rapid, or as you can see with a high variability. But in some of them, really, there's no response at all, although you are treating for a prolonged period of time. Well, the question is, what are the mechanisms behind this variable response and this non-responsive state we see sometimes on dual therapy? And the mechanism behind that are not fully understood, but there are some explanation I would like to show you in order to better understand what happened. And it's most important if you treat with interferon that you are able to induce this interferon-stimulated genes. And if you are able to induce these genes, as you can see here, by giving PEG interferon, then you have a very nice antiviral response. You have a kind of an antiviral state within your hepatocyte leading to eradication of the virus. But what have been shown in the non-responder state that your interferon-stimulated genes are already pre-activated. They are highly but ineffectively upregulated. But they are not only ineffectively upregulated, they prevent the response, the further induction of these genes when you give interferon. So it's a quite interesting concept, also leading to the question whether we are able in the future, in order to improve backbone activity of PEG interferon and ribavirin, whether we are able to deal with this upregulation, whether we have in the future some chances to downregulate these interferon-responsive genes, and whether direct antivirals may be helpful in this respect. This is a situation, and it's completely different if you treat with a direct antiviral. Here you can be quite sure that every patient taking his pills will have a very rapid response on this antiviral treatment, as depicted here for tenofovir monotherapy, but quite similar picture for boceprevir monotherapy. You can expect within days a nice decline here for tenofovir in the range of 3 to 4 logs within a couple of days, a viral decline. But you can also see that you are not able to induce a complete response with undetectable level in most patients. And then what happened is that there's a kind of a plateau phase, and there's the selection of resistant variants also quite rapidly, and within days these variants may become the dominant viral population, leading to virologic breakthrough. So it's a highly dynamic process, and especially the early treatment phase are most important in order to prevent the development of resistance. Well, for pretreated patients, the individual response pattern to PEG and interferon treatment has very huge implication for the use of a protease inhibitor-based triple regimen. So if you have a patient being a null responder, then the chance that this patient will receive a kind of a functional protease inhibitor monotherapy, as I've shown you, is quite high. In contrast, those patients that have been proven that they do respond to PEG and riba are probably the best candidates best selected that they may respond with a triple therapy, because you have additional help with a third drug to your PEG and RIBA, and the chance for cure is quite high. And this is not only theory, this is what was clearly shown also in clinical practice, and I show you here the data on treatment failure. And on-treatment failure is nearly always associated with the development of resistant variants with either a boceprevir or tenofovir triple regimen, according to the individual profile of the patient, according to the prior treatment response state. And indeed, even as compared to the treatment-naive patients, those having a relapse have the lowest likelihood, the lowest risk of developing on-treatment failure. It's less than 1%. So the concept clearly holds true. If you're responding to interferon and ribavirin quite properly, then the addition of tenofovir has a very high chance for cure. The partial responders, you see breakthrough rate or an on-treatment failure rate in the range of 18 to 20%, but especially for the null responder population, more than 50% of the patients will develop viral resistant associated breakthroughs. And I think the problem is best illustrated by this very well-controlled study. These are data from phase 2 development program, and patients receiving the placebo, so only dual therapy, had the chance to be retreated. And there was a very close monitoring of viral kinetics during the first treatment when patients received only dual therapy with placebo. And this is depicted here for the group of patients with a null response. This means less than 2 log decline in the first 12 weeks of treatment on dual therapy, and as you can see, really quite stable viremia. And you see what happened when these patients were retreated with triple therapy. As I mentioned, in all of them, you have this very nice effect of the protease inhibitor. So all patients initially do respond to treatment. But in many of them, you will find a viral kinetic as seen in monotherapy. Within a very few couple of weeks, viremia restarts as a rapid increase with the development of viral resistance, and you end up with a very low cure rate in these patients. So, in this slide, I would like to summarize the experience we have from phase 3 trials with boceprevir and tenofovir on the SVR rates according to the pre-treatment status. And this is shown here in comparison to the treatment-naive situation. So we have the relapsers, partial responders, and the null responder patients. And you can see that highest response rates were achieved in the relapser patient, even higher as compared to the treatment-naive situation. And this is followed by 50 to 60% cure rates in the partials and a 30 to 40% SVR rate in the null responder patients. But although the overall response rates in the partial and null responder patients are clearly lower as compared to the treatment-naive or relapse situation, in comparison from what we have before with dual therapy, you can see the fold increase in SVR rate is even higher in those being null responder or partial responder, with a 4 and up to 6-fold increase in SVR rates. It's not only pretreatment status that has an effect and impact on SVR rate, also subtype matters, and especially patients with subtype 1a had a higher risk of developing viral resistance. And you see the effect of the viral subtype is most prominent in the group of partial responder patients, where those with subtype 1b had a significant better chance for cure, with nearly 70% as compared to 47% with genotype 1a. Also, stage of fibrosis matters, and you will hear more about in the next talk on liver cirrhosis. But again, especially for the partial responder patient, you see a declining percentage of cure with increasing stage of fibrosis and the lowest chance for cure in the cirrhotic patients. And similar data, I would like to show you all in duplicate also for the boceprevir triple therapy. Well, treatment regimen for pre-treated patients differ according to the pre-treatment status and to the stage of fibrosis. So you have to differentiate the relapser patients and the cirrhotic patients. And first of all, the regimen are depicted here for those having a relapse and no cirrhosis. Here, the regimen with the boceprevir triple therapy start with a lead-in, followed by 32 weeks of triple therapy, followed by a maintenance with dual therapy. In contrast with tenofovir, in this situation, we have a response-guided concept, and according to the rapid response status, you can treat patients only for 24 weeks. If not achieved an extended rapid response, then you have to continue maintenance therapy. And I think there are some new modifications that can be quite interesting for relapser patients. And keeping in mind that you can cure now nearly 90% of patients with relapse, probably you're overtreating a significant number of patients, and you probably are able to reduce treatment duration in some of these patients. And this is, again, a phase 3 trial evaluating whether you can shorten treatment duration in treatment-naive or relapse patient type 1 if they have favorable response predictors, and this means a favorable genotype, IL-28B, CC, and no liver cirrhosis. And these patients, if they achieve a rapid response at week 4, were randomized to receive standard of care 12 plus 12 weeks, or treatment was stopped with a total of only 12-week triple therapy. And we have first results presented at the EASL meeting some weeks ago, clearly showing that this is a very effective treatment option, and that the cure rate, even with a 12-week triple regimen in this situation, can reach 90%. And I think this can be an important option, especially for those patients developing side effects and where you might consider whether it's safe to stop treatment early. For all other patients, this means the partial, the null responder, and for all patients with liver cirrhosis, standard of care with a triple regimen is a full course of 48 weeks of treatment. Some differences with respect to the tenofovir-based, the 12-week triple followed by the 36-week of dual maintenance, and again the lead-in concept followed by a boceprevir long-term treatment, especially for the cirrhotic patients. Well, Mark already mentioned the big debate whether we should wait for better treatment option in treatment-experienced patients. And I think this may especially hold true the debate for those having low response rates on triple therapy, and these are the null responder patients. And you will see a lot during these meetings on how many treatment options we probably will have in the future, and these can be either interferon-based or interferon-free, also showing in null responder patients very high rates of cure. However, in the meanwhile, I think we also can discuss whether we can better characterize non-responder and especially null responder patients who are likely to respond and may profit from triple therapy now. I mentioned the different response predictors we have seen, and many of them we know already from dual therapy. So main predictors also in triple therapy are the stage of fibrosis, genetics, the viral subtype, as I mentioned, and viral load. Of course, treatment adherence, the PEG-RIBA response, and there are certain blood markers like the level of GGT, the higher, the worse is the outcome, and cholesterol, especially LDL, the higher, the better. What we would like to avoid is resistant development, and I mentioned that this is quite high, especially in those with null response. And here you can see the typical profiles or the different profiles on-treatment failure or virologic breakthrough we may see in patients on triple therapy and we would like to avoid. So we have a kind of a rapid breakthrough, and this means within the first 4 weeks of treatment you start with high viral load, but you end up with high viral load and you have this initial drop, and I mentioned this is mostly functional monotherapy. But sometimes we see also the situation of, I call it early breakthrough, within the first 12 weeks of triple therapy, and this is typical with a viral kinetic where you're not able to completely suppress viremia. You have an ongoing minimal viremia, and then the likelihood that variants become selected and you will suffer a breakthrough is quite significant. And then, and this is especially the case in the tenofovir regimen, when you stop after 12-week triple therapy, you may see a breakthrough on dual therapy. And we have learned that we have clear phenotypes that can be associated to these different types of breakthroughs. So this rapid breakthrough is mostly seen in the prior null responder patient and in those with adherence problems, the early breakthrough associated with partial response, and, as I mentioned, the subtype 1a and unfavorable genes, host genes, and relapse at the end of treatment or after stopping triple therapy is clearly associated also with liver cirrhosis. The next point I would like to discuss is whether we can use a lead-in to better predict to the individual the treatment outcome. And I think this is a quite interesting concept, and clearly if you have a good response on lead-in, and this is defined as a more than 1 log decline in viral load, your chance for cure is quite high, with nearly 80%. But the problem we have with a lead-in, that even if you do not have this favorable response during the lead-in phase, 1/3 of your patient will eventually achieve an SVR. So it's not an optimal predictor for the individual, statistically highly significant, but does it really help for the individual if you have a 30% chance for cure? And to make things even more complicated, if you combine it with different other predictors of response, like the subtype, stage of fibrosis, the viral load, you can see significant differences according to the lead-in and with respect to the SVR result. So if you look in a patient population where you have no response during the lead-in, less than 1 log, the chance for cure in a subtype 1b patient, in those with low viral load or no cirrhosis, can be significant, 49, 54, or 38%. The concept of lead-in was also evaluated in tenofovir triple, and here you see the kinetics in those started immediately with the triple therapy, or those starting with a lead-in followed by the triple therapy. And you see the viral drop, the kinetics are clearly identical. So in my opinion, it's even more important not to see only the individual interferon responsiveness during the first 4 weeks. It's most important to see how a patient responds to triple therapy. And indeed, these data clearly show you that the individual response to triple therapy after the lead-in, this means 4 weeks after starting boceprevir, this means at week 8, is probably the best predictor for the individual who is likely to respond and achieve an SVR. So in the group of patients with poor response during lead-in, if you achieve undetectable levels 4 weeks after starting triple therapy, then your chance for cure is quite high. If you have less than 3 log decline, your chance for cure is 0. And if it's less than 4 log, it's only 16%. Quite similar data for tenofovir, even in the null responder situation as depicted here. If you achieve a rapid response or an extended rapid response, the chance for cure is quite high. So basically the concept holds true. You can start with triple, you can see whether there's an early response at week 4, and if it's achieved, the chance for cure is high. I would like to come to an end and just some brief words to the role of ribavirin. We know that ribavirin is quite important for dual therapy in order to prevent relapse. We do not really know how it works, but now with triple therapy we have some problems with ribavirin, especially due to the anemia, and there's a lot of debate whether ribavirin dose is too high, whether we should reduce it quite early. So some brief words on probably new and interesting findings how ribavirin may work and how we deal with dose reduction in the pre-treated situation. And again, coming from the EASL meeting, there are quite interesting data on a new mode of action of ribavirin. I mentioned in the beginning that probably a major problem of the PEG interferon non-responsive state is that you have these upregulated interferon-stimulated genes, but that this upregulation is ineffective and you're refractory to further activation. And there are now some data showing that ribavirin may restore kind of a reprogramming of the system so it can again be ready to be activated. And that clearly shows that ribavirin still is a very important player, and probably it's quite important to have a high dose, at least in the beginning. And again, from the EASL, there are some data being in line with this concept that it depends when you reduce the dose, what happened to the antiviral effectiveness of your treatment. So as shown in many other studies, a ribavirin dose reduction with respect to the induction of a complete on-treatment response, whether you reduce it between week 4 and 12 has no impact on your early virologic response pattern, and it's identical as if you compared it to a group of patients without any ribavirin reduction. But the ribavirin reduction within the first 4 weeks was associated with a lower on-treatment response rate. And this was especially seen in the null responder patients with advanced fibrosis. If ribavirin was reduced quite early, only 44% responded to treatment in comparison to those with a later reduction. So, Mr. Chairman, ladies and gentlemen, I would like to summarize. Treatment experience per se is no unfavorable factor for treatment outcome using protease inhibitor-based triple regimen. And the highest chance for cure in patient can be seen in patients with relapse and called good partial response. On the contrary, we have the highest chance for on-treatment failure in null responder patients with subtype 1a, with cirrhosis, high viral load, and low LDL levels. The individual value of lead-in phase in viral kinetics in order to predict who is going to respond to direct-acting antiviral regimen is questionable, and regardless of the individual predictors, if a rapid virologic response is induced, the chance for cure is quite high.